Thank you very much, MEC, members of the media, and senior leadership in the department, and fellow South Africans. We just want to give a quick sense of our visit into KwaZulu-Natal. As the MEC is indicating that I haven't been KwaZulu-Natal for quite a while, but in fact, this was the first province I came to when we spotted the first patient. And we spent the whole weekend at that time, and it sounds like many years ago when that happened. But we have actually, as the department, as well as South Africans as a society, have moved a long way from that point. We're now living with the reality of COVID-19. As we said before, COVID-19 is no longer a story that we read about from China, from Italy, from America. It is a reality where now each one of us can talk about friends, relatives, colleagues who have suffered the infection. And so it makes it very, very different from the time when we started talking about COVID-19 at the beginning of March. Now, what we have also seen is that through our models and the reality on the ground, we were expecting that the numbers were going to increase, and so we expected a surge to come at some point during the winter months. And when we put up the lockdown, we did say that we would never stop the infection from rising, and we will also anticipate that there are many people who will be infected, and that literally anyone can in fact be infected. That is now a reality that we are living in. And so what we have seen in the past few months has been a very different presentation of the COVID-19 pandemic from what we initially thought was going to be. Initially, we thought that this was going to be a huge surge in the whole country, starting with Gauteng being the highest, and KZN and Western Cape and so on. And of course, it has completely changed. Firstly, the surge didn't come quite as early as June, May, June, when we initially thought it would have come. And all our modelers indicate that the fact that we had an early lockdown deferred the surge to about June, July, August. And so in that process, we have actually seen that for all the provinces, there were about 2 to 3 months when there was quietness, not much movement in terms of the spread of the infection. Although the numbers were growing, they were growing very slowly, and except for the Western Cape, which broke off immediately and started growing within the first few weeks of the lockdown, and the numbers went so high up, and we were very concerned about this, but we have also then been visiting the different provinces. Western Cape, I spent quite a lot of time visiting, and Eastern Cape, and of course now Gauteng and all the others, particularly Free State and Mpumalanga, when we're picking up some early signs of the infection getting out of hand. Now, yesterday I presented a pattern which is what is now seemingly the reality of how this infection is going. The pattern is indicating that the trends of an early surge in the Western Cape and peak and then plateau have actually now been confirmed as a reality. We for a while didn't want to talk too much about it because there was no explanation from our side as to why the pandemic would behave like that. We've asked all the clinicians, the scientists, the researchers, and no one could actually explain. But we did confirm that at that point the numbers of patients who were coming in did not match what was anticipated by the hospitals, as well as although the numbers of fatalities was high in Western Cape, it did not reach what we thought was, what we feared was going to happen. In particular, if you saw the challenges that took place in Spain, in Italy, in America, and so on. Now, this to us meant that there might just be slightly different presentation of the pandemic in the country. So for almost 2 months now, the Western Cape has shown not only a plateau, but also is showing decreased numbers in terms of people who are presenting in hospitals and the numbers of tests that people are finding positive. And we always focus on it because we had lots of challenges with tracing and tracking, quarantine. It didn't happen too well, but nevertheless we've seen the pattern of the infection. Now, about a few weeks later, excuse me, the Eastern Cape and Gauteng started lifting off, and the Eastern Cape now has actually plateaued at a slightly higher level than what the Eastern Cape had done, and it's now about 3 weeks that it's been slowly on a downward trend, and we are now observing what is happening there. And I think all of us have seen that in the past few days we've been seeing low numbers of tests being done. But the point is that the trends have been generally a downward trend, although we look at the tests with the changing criteria that we used. We are focusing on the most high-risk areas who are vulnerable, those who are under investigation, and those who present themselves in the hospitals. And so we have nevertheless seen that there's a slight decline. In fact, some of the major field hospitals, whether it's City ICC in Cape Town, whether it's the VW in Port Elizabeth, or in some of the large field hospitals that were set up that have not really filled up. So I think the first thing that we've noticed is that we didn't breach our hospital bed capacity. Every time we had a press conference, I would be asked by the media, sometimes 2 or 3, 4 times in one press briefing, is South Africa ready? And we said, yes, we are. And then they said that there are these problems, and we said those problems do exist. However they exist, they will need to be solved. But at the same time, we are focusing on how to deal with people when the infection arises. And so we have been able to make that kind of impact. I think the lockdown helped us to defer the peak for a while, and therefore we're able to deal with the issues of the numbers of beds. Then we looked at the Gauteng. Gauteng took off with a very high rate of increase, and up to giving us between 5,000 and 6,000 positive cases in a day. And we actually were very worried, and we spoke to a number of the clinicians on the ground. The hospitals were feeling the pressure, and there were some reports, in fact, that said people can't get admitted in hospitals, they're being turned away, and so on. However, we looked into that aspect, and we found that, in fact, the admission wards, the admission centers on the outpatient basis is where the challenges were. And what happens here is that we made given a directive that all hospitals must now create triage centers where you separate the patients up. If you are not sure, put those patients aside. If you are sure that they are negative, then you put them on to the negative side. If you are sure they are positive, you put them on the positive side. And that created a bit of a bottleneck. We had to then run quickly into Gauteng to open up that space. And then, of course, there was the issue of the tests, which was delaying and making it difficult for someone who's under investigation to be tested and the results to return quickly. We cleared the backlogs, and the last we discussed with most of the clinicians, the situation is that there's quite a lot of the hospitals are quite busy in Gauteng. However, we're not at a point where there are problems of no beds available. In fact, the Newzroom field hospitals on the second week when I went to visit, of available 500 beds or so, we actually had not filled more than 150. And it remains available at this point. What I think has assisted, and all the clinicians on the ground have attested to this, is the fact that there's been a suspension on alcohol, and this has reduced the trauma, motor vehicle accident, interpersonal trauma, the assaults, the gunshot wounds, the knife wounds and stab wounds and pangas and all of that has been reduced. Now that makes a huge difference, because then it means, firstly, when people come in, you actually can attend to the very sick ones who now are as a result of COVID-19. And in this case, Gauteng has actually been coping pretty well with a lot of challenges, but is still coping pretty well. We have now seen in the past 3 weeks the trends from the testing in numbers in Gauteng is on a downward trend. And so the one province that remained with numbers that were high, that were increasing, is KwaZulu-Natal. And it seems, therefore, for us that the surge in KwaZulu-Natal came about 2 weeks after Gauteng, and 2 weeks after the Eastern Cape, and probably just about 6 or so weeks, was 6 or 7 weeks behind the Western Cape. So we must therefore focus on KwaZulu-Natal. And in KwaZulu-Natal, the numbers are such that now KwaZulu-Natal is the third highest in terms of numbers, whereas at the beginning it was the second. Right later on it became the third, the fourth largest numbers. Right now it's the third largest numbers. In fact, my expectation is that sometime during the course of next week, KwaZulu-Natal will have more positive patients than what we recorded in the Western Cape. Western Cape is in a downward trend, KwaZulu-Natal is an upward trend, and the numbers in the KwaZulu-Natal right now have been ranging around the 3,000, 3,005 and thereabout, and in such a way that in some of the days, in fact, KwaZulu-Natal had more positive cases per day, per 24-hour, than Gauteng. Now, this is the matter that has been of concern to us, that the province needs to be ready, and so we came here to assess that readiness. And certainly we have said this time we'll just always make sure that we look at the big cities and look at the small hospitals. So this morning I have been around, I got a briefing. I am firstly satisfied that the records of what numbers of patients and how the recording of the epidemic in all its different algorithms is actually being done properly. We met with the epidemiologists. They gave us a whole report, which I'm quite happy with. And secondly, we have seen that the numbers of patients are increasing who are positive, as well as the fatalities are increasing. But what is important for us is that there is no hospital that is already full to an extent that we no longer have beds in the nearby hospital. One thing that has been helpful both in the Western Cape and Gauteng is to create what we call the Bed Administration Bureau, which means that for every either district, excuse me, for a district there must be a central location where there would be a recording of the available beds. This helps now when someone picks up a patient who is sick and the ambulance services pick someone who is sick, they phone this number and then they actually get the patient directed to that hospital rather than being taken to an area where they might be under pressure. This is what we learned as well, both in the Cape Town and Johannesburg, and the problem was that if one ambulance goes to one hospital and then they're told, look, we're full, and then we go to the next one, even if they've now got a bed later on, the message that goes out would be that the hospitals were full. So this is working well now, and I'm very pleased to see that that's working. In fact, I've now been told that the number is made available even to the patient, so that someone can actually call and then they can decide whether the bed is available in such a place, and they move the patient where the patient will be assisted within the Durban-eThekwini region. Now that for me is a very good indicator of the fact that patients aren't going to fall off the cracks as a result of whatever problems might arise at any level. We've also seen that the occupancy, the bed occupancy is still fairly low, and therefore that means that the surge, as it comes along, we will be able to accommodate as many of the patients that might be coming up as possible. So I went around, therefore, to have a look at Edenale Hospital. I was very impressed also with the way that they've organized their triage system, which is actually working fairly well. And I've also then seen that they actually fielded very senior professional nurses onto the front and senior specialists to be the ones who are at the reception area, so they make a very accurate assessment of the patient and move them to the right places. We have also heard that there were challenges in some of the hospitals, such as Northdale Hospital, where the accommodation for patients was unacceptable. I am pleased that there has been action taken in this regard, because we must actually make the point to the management that we want them to hold them personally responsible and accountable for any treatment that is below the expected. And so, both in terms of the management of the protective gear for the health workers, as well as the care that the patients are receiving, we will therefore put a spot on investigation and then ensure that there's action taken at that level. In this case, the issue of Northdale has been reported to me, and we are aware that this matter was circulating in the social media. Actually, even before it was out in the print media, we had spotted it and had already directed that the MEC must investigate the matter. And so we've got the report that there has been action taken in this regard. I think it must be a message to all the management that we would like them to take their responsibilities quite seriously, because there will be action taken on those who are not managing properly and those who are not ensuring that the quality of care to the patients is maintained, and those who are not ensuring that the protection to the health workers is not properly managed. And this is important because we say that our health workers are the soldiers. Now, a soldier goes into the battle, must be fully armed and fully kitted with protective gear, and they must be fully trained in terms of understanding the tactics of fighting, in this case, how to avoid the infection, so that they can save many more lives, rather than they themselves having to fight for their own lives. So we have got the report now from Northdale Hospital, and then I then had a visit at the Richmond Hospital. Now, this is a small rural town, and this hospital was a highly neglected hospital, which was mainly a TB hospital. And over a period, it really got dilapidated and was not being used, not even useful to the local community. And so I was also pleased to see how much work has been done, refurbished, good, looking as good as new, and with oxygen points put in place, and the best of infection control procedures are accommodated in that hospital. So clearly now the Richmond community has now got a district hospital, because when COVID-19 recedes, that hospital must now be opened up as a district hospital. I have come now to the Clarewood Hospital. Now, I used to work here. One of the most dreary looking hospitals, neglected hospital, was Clarewood Hospital. It does look good as new now. It looks well refurbished, and I've also been impressed to look at it and to see that it's really got a refreshing appearance. And all of that is for me very, very important, because we now are able to use that hospital to just get about 190 beds, which I think it would be useful for the nearby hospital to push their patients and refer them into this area. On the other side, we've actually been able to see one of the field hospitals rolled out within a very short space of time of about 5 weeks, and that it was even because there was a bit of a protest that delayed it for another week. So it could have been completed within 4 weeks as such. To about 228 beds, which is a very good number. So it certainly converts the Clarewood into about 400 beds. For the southern part of Durban, Tegwini, is a very useful contribution. In particular, it will be serving the Wentworth and the Nkosi Albert Lutuli area. So you've now got a very strong program of movement of patients from field hospitals for very mild symptoms, and then to more focused treatment in the wards, as well as the possibility of putting up a high care. which I think is very good. But anyone that complicates, they've got all the big hospitals nearby. And the cooperation between the department and the university, the tertiary hospitals and the professors, we've met them on the ground, and some of you would have seen the professor head of Department of Medicine. That is one of the things that's really making this thing to be a very collaborative process. So this is on the south of Tegwini. In the north, we went the last time on our visit with President to see Pixley Isagaseme Hospital, which has got 800 beds. We haven't actually started using it. It's ready to be used, and therefore we are then saying that even if there would be a surge at any one time that increases from what rate we're seeing now, we've got possibly another 4 to 5 weeks even to roll out a new hospital anywhere where we might think we need it. And so I think that the province is pretty much on course in terms of readiness. We will be visiting some of the rural municipalities, the area of Madlangeni tomorrow. I worked here, as I said before. They focused on some of the neglected hospitals, and the idea for me is how some of those neglected, dilapidated hospitals get revamped so that when we talk about instituting NHI, there are new additional hospitals that are now useful that could have been a challenge in the past. So we are going to be working together to ensure that the issues of staffing are taken care of. We're also going to be making sure that the issues of PPEs for the staff is also taken care of, and that we tighten up management. Management needs to really manage, and they must work together with the trade unions and ensure that all the issues and the challenges that are being raised by staff and members of the unions are attended to, so that as we move on, the issues of occupational health and safety of our staff is taken as priority. The staff has got to be looked after. We have to make sure that our health workers don't continue to be infected, and certainly if they are, they shouldn't be infected from within the hospital setting. We do know that many of us can also be affected at the community level, but we need to make sure that the infection does not really cross from patient to staff, and from staff to patient, and from colleague to colleague. So that's what we want to emphasize upon. Having said all this, we are not ready to give the figures right now. Quite a lot of compiling happens behind the scenes, and therefore it will not be complete at this point. And so there are some which are ready, some which are not. So we'll release the statement a bit later. But I think what becomes important at this point is just to indicate that we have taken seriously the analysis in terms of the trends, and we think that what we are seeing in terms of the downward, promising downward decline. I say promising, excuse me. I say promising because we always want to wait for a few weeks and confirm that the trend doesn't turn around. But we want to thank all the South Africans who have heeded the requests and the directives to focus on containment. Those who have worn the masks and washed their hands frequently, used sanitizers, cough etiquette, as well as distancing, have actually given us the trends that we're seeing. They have made us have the infection, kind of sloping downwards in the way we're seeing. The fact that even in the Western Cape and Eastern Cape we're not getting towards zero is because there are still many more who are not wearing masks. The fact that we're not getting to a point where we say we've got no new infection is because there are still many more people who are not washing hands, not using sanitizers, and not distancing. So this is the message that we want to send to our people. Please, please, please let us use masks when we get out of our homes. Let us make sure we wash our hands. Let us make sure that we sanitize our hands. There are challenges that we can see because after about 3 weeks, we'll have a better sense of where the trends are in the country. Now, if this situation continues and more people use masks and distancing, then we might find a situation where there would be much, much lower levels of infections. So there's been a question that's been raised about why are we seeing rate of infection decreasing? Well, there will always be variations for various reasons. Variations where, like 2 days ago, they test to about 20,000 tests. Then after that, it's about 34,000, it's about 40,000, and so on. Those on their own don't compromise our calculations. However, we have checked on a number of areas to say what is the reason why there are fewer tests. In some of the instances, they've said to us that they are not having enough patients under investigation who are coming with the symptoms that would have warranted them to be tested in the way they were tested before. There are also instances where they've been indicating that as they were going around testing, there are fewer people that needed to be hospitalized and therefore needing to be tested. But somebody asked me a question, why are we seeing more testing in the private sector than in the public sector? Well, in the private sector, whilst the people are following and using the protocols, there's also still quite a number of people who are who request to test. You have seen that people would go to some chemists, some of them, and get themselves tested. But also in the private sector, the testing went up to a point where the people who were going to be getting operations, they would actually even be tested, even though it's not a protocol requirement through WHO, but they've been doing quite a lot of that. So those are some of the variations, but it does not, as we analyze, yet distort the situation. In any case, as we move along, we keep adjusting our protocol for testing. We've actually asked the Ministerial Advisory Committee to look at with the numbers the way they are doing, and if we're running short of numbers in the way that some of the areas are doing, we might still want to keep the level of testing high, and therefore it will give us a proportionality that must show a decrease if the numbers are fine, but we shouldn't be having a concern that there are too few tests that we are doing. And so we are asking the Ministerial Advisory Committee to have a look at that and see whether in fact we would vary the criteria just to be able to make sure we cover in the areas where the numbers of patients are declining, so that we can keep a high level of testing. So we want to focus on that. The other issue that I think has become important for us has been the fact that on an anecdotal basis, as we have actually had a number of instances where people will get a kind of flu-like illness, and within 2-3 days then they pass, and we want to send a message to our communities that people must go to hospital. We would like people, don't stay at home and say this flu is going to get better. Get the hospital to test you, treat you, and decide whether you get to treat yourself at home or whether you stay in the hospital. And if you are admitted in the hospital, don't rush to leave hospital. Wait until the doctors decide you need to go back home. And this is all important because when we were analyzing in the past few weeks, there's been a debate about what is called excess deaths. Now, excess deaths are deaths that when you analyze daily deaths over in every week, and compare with 2 or 3 years ago, you will find that there are numbers that are a bit higher. In this case, in South Africa, this was done, which was done 2 weeks ago, and when the figures were released, there was a lot of excitement that maybe we are undercounting the deaths, we are not reporting or under-reporting death. Well, actually, we're reporting as much as possible. There are 2 areas which I think are blind spots for many people in different countries. One of those is the issue of people who would have died before they are diagnosed, and those people, when they die before they are diagnosed, may have died of COVID, may not have died from COVID, and no one can ever know. And so if we looked at different countries, we found that the numbers were high in many countries where during this time they were finding a number of people who had passed, and therefore we look at this concept of excess death in that way. We are therefore going to be encouraging that our departments must talk to the funeral parlors. People who died home, we need to make sure that we can swab them, just get a quick sense of whether they could have had symptoms suggestive of COVID, so we can swab them, because the excess death contains two groups of people. There would be those who would have died because of COVID, but no one diagnosed them, so no one knows it was COVID for sure. But we do know that they are there, so by the proportionality, nobody can tell. On the other hand, there are those who would have died of natural diseases, things that they would have been suffering from before, but in the process, they are not able to go to the hospital, either because they feel that they are safer at home, and then of course the disease complicates, or they fear to get to hospitals, or they might feel that maybe the hospital is full and so on. There was a time when we had actually decanted our hospitals and encouraged everyone to go home and treated as many people out at home. We are saying we would like people to actually come to hospitals for basic services. Immunization is very important, that the children must be immunized. Well, baby clinics, so that we monitor their growth, their weights. It's very, very important. Contraceptives for family planning, very, very important, so that people can manage their lives properly. And chronic diseases, diabetes, blood pressures, heart diseases, cancers, and so on. We wouldn't really like someone to be someone's life to be compromised by some disease that was under control, and then all of a sudden, because they can't go to the hospital, their treatment is therefore undermined or disturbed. And so we want to encourage people to come to hospital as much as is possible. We have a space because we actually have reduced trauma, and therefore we believe that we must focus on the real issues, not on avoidable problems, causes of ill health. And so our plea then to our people are that we deal with that.